تتفضل الدكتورة ياسمين مين؟ الدكتورة منار مأمون، مدرس الإشعة التشخيصية بطب عين شمس، تتفضل المحاضرة بتاعتها بعنوان Imaging of the Facial Cosmetic Procedures.
Good afternoon. First, I'd like to express my pleasure to be with you today. واضح كده؟ Okay, I'll talk about a light topic, which is imaging of the facial cosmetic procedures. We will have an idea about the imaging appearance of the common rhinoplasty procedures and implants to adequately interpret their post-operative radiologic findings and to adequately interpret the common potential complications and to avoid misinterpretation. First, I'll start with rhinoplasty, which is surgically modifying the shape of the nose, either for functional or cosmetic purposes, or both. It's a common procedure, so it's not uncommon to encounter the sequelae of rhinoplasty on head and neck imaging. Cosmetic rhinoplasty include modification of different parts of the nose. I'll start with the radix, which is the root of the nose. Radix modification could be reduction versus augmentation. Here, an example of augmentation of the radix, where you can notice a bone graft fixed with a screw. Another case of radix augmentation associated with nasal dorsum implant, hyperattenuated. Augmentation can also be done with an autograft like bone graft. The bone graft appears with hyperattenuated cortex and internal fatty signal of the bone marrow. It could be best visualized on MRI, where the fatty bone marrow show hyperintense signal and the cortex is hypointense. Nasal dorsum surgery could include dorsal hump reduction that can be done with reduction surgery as shown here. Compare it with the preoperative hump. Septoplasty either done in association with rhinoplasty or alone based on the patient's complaint. In post-septoplasty cases, you can notice the nasal septum to be very straight and thin and without any spur compared to the preoperative scan. Another surgical intervention frequently encountered is lateral osteotomy, in which surgical fractures or osteotomies are done in the nasal processes of the maxilla bilaterally or unilaterally to be able to narrow or widen the nose or fixing a deviated nose. On imaging, the osteotomy site usually visible as osseous defect or green stick fractures for about 6 months, after which remodeling usually occur and you hardly notice the defect. You shouldn't mistake these defects for being fractures. The nasal tip is also called the lobule, subdivided into tip lobule, supratip, and infratip. Tip modification procedures include augmentation, either using graft or implants, usually done in association with nasal-based surgery that includes modification of the columella and ala. Here you can notice two implants, one at the nasal tip and one at the columella. Nasal-based surgery could be done alone for cases like retracted columella and usually combined with nasal dorsum surgery. Here you can notice an L-shaped silicone hyper-attenuated implant extending over the nasal dorsum to the columella. Premaxillary augmentation can be done alone or can be in association with rhinoplasty to treat cases of premaxillary retrusion. Usually you can notice an autograft or implant positioned anterior to the nasal spine of the maxilla. You should be familiar with the appearance of the metallic K-wires that can be used to fix nasal septum fracture or stabilizing a costal cartilage graft. It's usually inserted into the maxilla lateral to the incisive canal. Another topic is the dermal fillers. They are gel-like substances that are injected beneath the skin to restore lost volume, smooth line, and soften creases or enhance the facial contours. There are many types of the injectable facial fillers that could be categorized according to their biodegradation timing into short-term intermediate, and permanent. Nowadays, the most commonly used fillers are the hyaluronic acid, polylactic acid, and calcium hydroxyapatite. There are typical locations for fillers injection. You can use these common terms in your reports, including malar, cheeks, or temples. But you should mention whether the fillers are superficial or deep to the superficial musculoaponeurotic system, which is a 3D fibrous network connecting the dermis and the periosteum and the superficial expression muscles. Yet, the superficial and deep compartments are actually subdivided into smaller fat compartments separated from each other by fibrous membranes. The facial fat in these compartments have different aging timing. So, thorough knowledge of the facial fat compartment is needed in head and neck imaging reporting for better understanding the facial imaging fillers distribution and migration. These MR images are from a very useful paper published on 2017 in Science in the Imaging Journal. It helps you to localize the different facial compartments. Here is the superficial musculoaponeurotic system. Superficial to it is the medial and middle cheek compartments. Laterally, the lateral superficial cheek compartment. The deep compartments including the buccal fat band and the deep medial cheek compartment. This appearance on MRI of the hyaluronic acid, which is the most commonly used facial filler nowadays. Examples of the commonly injected locations: lip, superior and inferior lip, premental space, superficial cheek, malar cheeks, and extending over the temples. Here is over the temples. Most fillers show fluid density on CT images or soft tissue density, like in this case, where hyaluronic acid was injected in superficial, middle, and medial cheek compartments. Silicone appeared denser than any other used filler, approaching the density of bone. Autologous fat can also be used. It shows fat density on CT and MRI. Hydroxyapatite, calcium hydroxyapatite, appear hyperdense calcified, usually injected in a streak manner, so to be differentiated from silicone. Most fillers like hyaluronic acid and collagen show high water content, so they show high signal intensity on T2 weighted images and low signal intensity on T1 weighted images. Calcium hydroxyapatite, that appears like calcific streak on CT, shows intermediate signal intensity in T1 and T2 weighted images. Silicone can be differentiated by silicone-only sequence. I'll show it later. The MRI protocol that should be used for such cases, including axial and coronal T1 and T2 weighted images, both before and after fat with and without fat suppression. You can use Dexon image. If you cannot get an adequate fat suppression, depends on stir sequence. Fat suppressed sequences helps us to localize the extent of the fillers more than any other sequence. Fat suppression sequence help you to identify the fat content of the filler or implant. Like in this case, it shows suppression of its signal. Silicone, if you don't know the material used, you should apply silicone-only images as in breast imaging. This is a silicone-only image done, but in this case, hyaluronic acid was injected, so the filler shows suppression of its signal in silicone-only images. This is a case of breast MRI showing a silicone implant. You can notice the high signal of the implant in the silicone-only images and suppression of its signal in water images. So include silicone-only images if you don't know the exact filler or implant used. Diffusion-weighted images are essential in such cases because they can discriminate abscesses inflammation, because the filler usually shows facilitated diffusion. It's in normal asymptomatic cases. Very common to have another problem for which you have an MRI, even you have previous injected filler. So in this case, there is a mass-like lesion that was mistaken initially for being a filler because the patient has frequent previous injected fillers, yet there was a diffusion restriction with mass-like enhancement, and it was proven to be a lacrimal sac squamous cell carcinoma. Fillers are not evaluated by PET-CT, but you can find it as an incidental finding, and it could be misinterpreted because many fillers have a normal high FDG avidity. So go back to the cross-sectional images. You will find them in their typical anatomic locations and with their expected imaging appearance. Another high FDG avid fillers, yet it form mass-like lesions, and it was pathologically proven to be foreign body granulomas. The third topic is the facial implants. Facial implants are solid materials compatible with the human tissues designed to enhance or augment the physical structure of the face. I'll give examples of the different implants used. This is a case of forehead augmentation by expanded polytetrafluoroethylene strips, Gore-Tex, usually positioned in vertical orientation. Example of cheek implants placed over the zygomatic processes, or submalar over the anterior maxillary wall. Implants can be placed in nasolabial folds and over the lateral brow for augmentation. This is an example of chin augmentation, which is called mentoplasty. Bone grafts or cartilage grafts can be used instead of the implants, as previously shown in rhinoplasty procedures, and you should recognize the cortex and bone marrow appearance, yet this appearance could be diminished on long-standing periods with resorption. Cartilage show soft tissue density on CT. On MRI, they have low T2 and high T2, low T1 and high T2 signal. Silicon appear hyperdense, but less dense than bone, best demonstrated on bone window. It shows a very low signal intensity on T1 and T2 weighted images. The radiologic finding of peri-implant radiolucent halo relates to the capsule formed around the silicone implant. This finding helped the surgeon to identify unknown implant before a re-implantation, before a second procedure. Example of Gore-Tex implant showing internal hypoattenuation compared to the silicone implant. Another implant called Medpore. Hydroxyapatite are similar in density to bone cortex, usually incorporated and inseparable from the adjacent bone. On MRI, they show a very low signal on T1 and T2 weighted images, yet you can see enhancement because they allow ingrowth of fibrovascular structure. Complications. There are various complications for rhinoplasty, fillers, and implants. Infection is the most common, usually occurring in the first 2 weeks after surgery or the procedure. It can be in a form of cellulitis, as is in this case, or progress to abscesses formation. Acute allergic reaction can simulate cellulitis, and infection can predispose to implant extrusion. Trauma also can predispose to implant extrusion or migration, as noticed here. Granuloma formation and calcification could be noticed after fillers injection, especially with the long-standing or long-term fillers. You can notice calcification on CT images. On MRI, you can notice soft tissue masses at the site of the expected filler injection. This is an example of silicone-only images. The lower image is a silicone material, so it's hyper-intense. The above image is a collagen material, so it's hypo-intense in silicone-only image. another case of granuloma formation showing associated fibrosis. Asymmetry is a complication consequent to overfilling on one side. Implant curling can be noticed and lead to deformity. Bony erosions are one of the complications, usually asymptomatic, but in pre-mental space, they can reach the root canal and cause pain. Hyperostosis are usually asymptomatic. Peri-implant calcification are frequently seen and usually asymptomatic. Osteotomy stepping can be seen in osteotomy operation where there is stepping of the procedure, so on remodeling, there will be a persistent bony ledge leading to another deformity. Saddle nose deformity can occur if the keystone junction of the nose is disturbed on surgical intervention. Nasal valve collapse is one of the common complications that require a second surgical intervention. It is the area in between the nasal septum, inferior turbinate, and the lateral nasal cartilage. Nerve impingement is the last complication I'll talk about. The K-wire can be displaced and erode into the incisive canal instead lateral to it. Thank you.
بشكر الدكتورة منار الحقيقة على this very interesting lecture، واللي احنا الحقيقة ما عندناش الخبرة الكافية فيها، ومع ذلك احنا مطالبين ان لازم نكون عارفينها كويس for encountering it in every day in our work، سواء بالسونار، سواء بالسي تي، سواء بالام ار اي. ومع انتشار البروسيدجرز دي قوي دلوقتي لازم ان all of the radiologists practicing لازم يكونوا عندهم وعي بالانواع المختلفه و how their appearance بالimaging modalities المختلفه، وازاي ان انا ما لخبطش بينها وما بين حاجه تانية، and how to pick complications. thank you very much for this interesting topic يا منار، ولو اي حد عنده اسئله.
اولا شكرا على التور ديت، والموضوع بقى كومن وبقى صح بنتعرض ليه كلنا سواء في الام ار او في الالترا ساوند. فانا سؤالي عن الكومباريزون ما بين الالترا ساوند والام ار اي، هل في بيبرز او حاجات قالت يعني امتى ان انا اكتفي بالترا ساوند او امتى ان انا احتاج اعمل ام ار اي، وايه الفرق في الافشنسي ما بين التو موداليتيز؟ يعني
في البراكتس الالترا ساوند غالبا هو البدايه، يعني هو اللي بيطلب الاول للعيان، بيوفي بالغرض ان هو اشوف جرانيلوما، ابسس فورميشن، الكومبليكيشنز اللي هي الكومن في حالات السوبرفيشال امبلانتس او فيلرز. المشكله بتاعته لو في الديب سبيسز اللي هي الديب فيشيال او في الباكال فات مش دايما بيجيب الاكستنت الكامل، فلو لقينا ان في ديبر اكستنشن الام ار اي هيوفر لي الريزوليوشن الاديكويت وهيوفر فيلد اعلى للايفالويشن. فغالبا الكومبليكيتد كيس اللي بتعملها ايفالويشن بالسونار لو لقيناه اكبر من الحدود المقبوله اللي اقدر اعمل لها ايفالويشن بالسونار هتجه للام ار اي بري اوبتيف، لان هو اللي هيقدر يديني الداتا اعلى. السي تي ما بنتجهلوش قوي، السي تي بيبقى غالبا انسيدنتال فايندنج بنلاقيها واحنا بنكتب اي تقرير تاني، لكن في البراكتس السونار ولو احتاجنا رنين بندخل عليه، وخصوصا لو انا مش عارفه الماتيريال اللي مستخدمه والاكستنت بتاعها، لان غالبا العيان بيقول انا يعني حطيت فيلر ولا هو مش عارف فيلر امبلانت اي حاجه يعني.
شكرا.
شكرا جزيلا. اي اسئله تانية؟ شكرا دكتوره منار for this interesting